My name is Montaña Brown, and I'm here to present the paper Vessel Segmentation for Automatic Registration of Untracked Laparoscopic Ultrasound to CT of the Liver. Liver resections are the standard treatment with curative intent for patients diagnosed with liver tumors. These are typically performed by a laparotomy, where the surgeon will create a large incision in the patient's abdomen to have full access to the liver, the tumors, and the associated vasculature during the resection. Increasingly, these surgeries are being performed laparoscopically. Given the minimally invasive nature of the procedure, the patients will typically experience less trauma during the surgery, which leads to fewer use of painkillers post-operatively and a shorter hospital stay. Overall, the laparoscopic approach means that a lower cost is incurred to the healthcare system. However, due to the complex hepatic vasculature, small field of view, and loss of haptic feedback to the surgeon, the laparoscopic approach is considered difficult, and as such, only peripheral tumors that are distal to large vessels and easy to access via laparoscopy are indicated for this type of approach. Overall, it is estimated that only between 5 to 30% of liver resections are performed laparoscopically. To facilitate laparoscopic liver surgery, intraoperative laparoscopic ultrasound may be used to image the subsurface structures such as vessels and tumors. However, laparoscopic ultrasound is hard to interpret because the field of view is relatively small relative to the preoperative CT scan. Additionally, obtaining useful ultrasound planes is difficult and requires a high level of operator expertise, as the laparoscopic ultrasound probe is a small transducer at the end of a long shaft, introduced by a trocar in the patient's abdomen. To aid in the interpretation of the ultrasound, it is useful to fuse it with the preoperative images, therefore providing more context to the surgeon on the whereabouts of the small slice of ultrasound in the CT. To achieve this, trackers may be used to relate the position of the ultrasound in space to the CT. However, tracking-based image guidance systems require careful calibration prior to each use. This necessitates a team of engineers to facilitate this method and increases the upkeep and complexity of the system. This type of alignment may also be achieved by considering image registration of the ultrasound to CT. However, using image registration to achieve this is challenging due to the small field of view of the ultrasound in comparison to the CT volume and the type of features present in both types of scans. Overall, the registration between laparoscopic ultrasound and CT is an under-constrained problem. Previously, a global initialization method to align untracked laparoscopic ultrasound sequences to a preoperative model has been proposed based on the use of vessel features in the laparoscopic ultrasound. To achieve this initial alignment, a database of possible laparoscopic ultrasound planes and their vessel segments is generated from a segmented CT volume. Then, a real laparoscopic ultrasound sequence may be aligned to the preoperative database by considering the vessel segments, as can be seen in this black and white plane, to the closest match in the CT database. To aid in the clinical translation of this type of method, the vessels in the real intraoperative laparoscopic ultrasound must be automatically segmented to allow for a fast alignment to the database. Several papers in the literature address the specific problem of vessel segmentation from hepatic ultrasound. Wei et al. In 2019 proposed a multi-class unit to segment hepatic vasculature from percutaneous abdominal ultrasound. Similarly, Thompson et al. Proposed a 3D unit to segment intraoperative abdominal liver ultrasound. In comparison to our data, abdominal hepatic ultrasound shows a different feature distribution of less variant vessels in terms of size and position. Additionally, our data is untracked, and therefore the laparoscopic ultrasound place must be segmented slice by slice without considering spatial correlations such as one would do with tracked 3D composited ultrasound. To date, there is no instance of deep learning-based vessel segmentation for laparoscopic ultrasound in the literature. Our work aims to assess the suitability of deep learning for vessel segmentation and its downstream applications. We choose UNet as our base model for vessel segmentation, considering its success at segmenting different types of objects in the field of biomedical image segmentation. The unit is trained with a dataset consisting of a sample of 1,844 images across 6 different patients. The data was acquired with a BK medical probe during laparoscopic procedures with no strict acquisition protocols. Considering the unequal distribution of patient data in our sample, as can be seen by the difference of number of images between patients 5 and 6 and the rest of the cohort, we considered it important to assess the variability of the UNET performance with different data set sizes and feature distributions and training. Therefore, we perform a 6-fold nested cross-validation, which consists of holding out each patient in our sample in turn and perform an inner cross-validation with combinations of 4 and 1 patients in train and validation splits. Then, we evaluate if models achieve statistically significantly different DICE scores by performing a Bonferroni-corrected pairwise t-test across the model results on the unseen test form. Our models obtain DICE scores in the range of 54 and 70%, which approach the state-of-the-art in ultrasound vessel segmentation. Additionally, we find that models trained without the largest patient samples perform statistically worse than other models in the same fold, as can be seen by this box plot in relation to the rest of them, and the variance in patient 6. However, as can be seen in this figure, overall the DICE scores are not very different between the best and worst performing models, even though there is statistical difference. It is well known that DICE score penalizes the missegmentation of small tubular objects in comparison to larger, more regularly sized objects. Therefore, it may not be the best metric to assess the performance of our model for the registration application. Since DICE may not be the best measure to evaluate our segmentations, we propose a novel measure called the vessel detection rate, which reframes successful segmentation as an instant detection problem. For vessels to be correctly detected, they must be close to the ground truth in position, and additionally must not exceed or be undersegmented by 50% in comparison to the ground truth vessel size. For each image, the average detection rate is computed by calculating the detection rate per each vessel in the ground truth segmentation. In this figure, we can observe the results of our UNET on different slices of laparoscopic ultrasound on different patients. And we can see that in the top, the large vessels are, generally speaking, correctly segmented, which results in very high DICE scores. However, we also find that where there is a mixture of large vessels and small vessels, detection rate is more indicative of segmentation success than DICE, as the correct detection of a large feature will lead to an average to good DICE score, but not necessarily a good detection rate. Given our downstream registration task depends on vessels being accurately detected across a different range of vessel sizes, we also reframe our detection rate measure to study the impact of training feature distribution on our model performance. We bin our data into 1 mm intervals according to vessel area, and measure how frequently features of that size are correctly detected according to our measure. In the left panel of this plot, we see a probability density distribution of vessels as binned by their size, with a peak between 1 and 2 mm. And on the right, we see the detection rate per bin over all the patients. We find that our models are more successful at detecting features in the majority bin of the feature distribution, as can be seen in the less variant high performance of vessels in the size between 1 and 4 mm, and the larger variance and generally worse performance for the vessels between 7 and 15 mm. This is clinically relevant, as our downstream application requires that vessels of different sizes be correctly detected to achieve a good registration. To evaluate this, we consider the detection rate and the DICE in relation to the registration task by retrospectively registering 5 sweeps of 6 laparoscopic ultrasound images using the priorly mentioned content-based image retrieval method. We then find the mean DICE score and detection rate per sweep and plot this against the TRE, which can be observed in these panels. For our evaluation purposes, a sub-20 mm TRE is considered a clinically relevant global initialization, which could be refined with further methods. For the clinically relevant registrations, we find that in all but one case, the detection rate exceeds 80%, as can be seen within this orange box. Whereas with DICE, these scores for the clinically relevant registrations range between just above 50% and 86%. Additionally, the detection rate shows a larger variance between the good and poor initializations. This suggests that the detection rate could be a better measure to evaluate the potential for the segmentations as part of a registration task. To understand the role of segmentation in the registration success, we showcase two registration examples, the top successful with a sub-20 mm registration error, and the bottom unsuccessful with a TRE of under 40 mm. In the first, we can see that a good global initialization is achieved, which can be attributed to the agreement between the segmentations of the laparoscopic ultrasound from our unit to the ground truth solution and the found solution by the registration method. In contrast, the lower example shows that a large segment is missing from the lower left corner of the laparoscopic ultrasound plane. This leads to an incorrect solution being found in comparison to the ground truth, and could be explained by the fact that our sample contains a smaller proportion of large vessel features. Therefore, increasing the number of images provided to our unit and feature distributions could possibly increase the performance in this realm. To summarize, we have presented the first laparoscopic ultrasound vessel segmentation results on clinical data, and have offered an evaluation of the performance bounds for UNET trained with a small clinical data set. We also present a novel measure to evaluate multiple image-wise vessel detection, and finally present the first results of a fully automatic, untracked laparoscopic ultrasound to CT registration that does not require manual initialization. Further work will involve including a larger patient cohort with a wider range of feature distributions to improve the performance of the models in large vessel features. Additionally, we could consider sequential models such as mask, RCNN, and include multiple classes in our segmentation to further constrain the registration. We would like to thank our funders, the Wellcome and EPSRC Center for Interventional and Surgical Sciences, and the CDT Eye for Health at UCL. Thank you for listening.